Hello, everybody. Welcome to Grand Rounds on this super snowy day outside. Hopefully, you've carved out an hour for us to spend some time learning about a really interesting topic from somebody who's a real expert in this, and that's Kevin O'Leary, who's the John T. Clark Professor of Medicine and the Chief of Division of Hospital Medicine and the Associate Chair for Quality at the Department of Medicine at Northwestern University's Feinberg School of Medicine, where he also serves as the medical director for quality at Northwestern Memorial Hospital. And for which, in recognition of his leadership in hospital medicine, he received the SHM National Award for Clinical Excellence in 2008. He's doing lots of fascinating projects um, on this topic, and we're really excited to hear from him. Dr. O'Leary.
Thank you, Matt. Appreciate the opportunity to share this presentation with you. I want to also thank Dan and Ryan. Ryan spent some time with me last week giving me a summary of your services and some of your past efforts in this area. So I feel like I'm pretty well prepared, and I've tried to tailor this for your interests. So the title of the presentation is Redesigning Systems to Improve Teamwork and Quality for Hospitalized Patients. I'm going to talk about first some definitions, and then I'm going to talk about some work that we've done at Northwestern. I'm at Northwestern Memorial Hospital in Chicago, and then talk a lot about an ongoing project related to this. So especially for the hospitalists in the room, who are listening, and you will recognize this topic. You're familiar with this. This has been discussed for many years. This is an article in the Hospitalist back from 2012 about unit-based rounding. Here's another article just last year, unit-based rounding in the real world. There's lots and lots of cover issues of today's hospitalists on related topics, whether it's unit-based rounding or interprofessional rounds or multidisciplinary rounds. All of these things kind of get conflated, and one of my goals here is to try to separate out and help kind of define these concepts and how they relate to one another. For the non-hospitalists in the audience, you may not have heard of all of these terms, but the concepts are going to sound really familiar to you, and more importantly, they're going to be applicable to your settings as well. The only disclosure that I have is that I've received past and current research funding in this area from the Agency for Healthcare Research and Quality.
Kevin, before you move on, we're still seeing your presenter notes. I don't know if you want to switch the display.
Oh, I'm sorry. Yeah, let me.
Yeah, exactly.
You know what? I'm going to, that's perfect, but I'm going to try to, now I'm going to be looking this way, and I don't know if you can see me, but I'm going to maybe move my camera so that I'm looking at the slide that you're looking at. How does that look, Matt? Okay, good.
Perfect.
So the only disclosure I have is that I've received past and current research funding from the Agency for Healthcare Research and Quality. The objectives for today, at the end of this presentation, you'll be able to explain how collaboration and teamwork influence patient outcomes. You'll be able to recognize system barriers to improve teamwork on medical services. You'll be able to describe interventions in the context of redesigned clinical microsystems and identify factors associated with successful implementation of these complex interventions. First, I want to talk about why collaboration and teamwork matter. And I want to make sure that we're all thinking about the team from the patient's perspective. So I want you to imagine a patient in a bed in your hospital right now and think about all the people that are taking care of the patient. Of course, in a teaching hospital like yours, there's the resident who works with interns and then attending and medical students. And a lot of times we as physicians, we really kind of concentrate on this team taking care of the patient. But of course, the nurse spends more time with the patient than the physicians do, and nurses work with other team members. In our hospital, we call them patient care techs, but the same role goes by different names in different hospitals. And then there's physical therapy and respiratory therapy and social workers and pharmacists. And sometimes the patient leaves their primary unit to go to a diagnostic or testing area where an entirely different team takes care of them for a period of time before they return back to their primary unit. And the primary care physician may not be physically present, but from the patient's perspective, they are definitely a member of their care team. I want you to take a mental snapshot of this slide because I'm going to ask you to recall it later. And the main point here is that there's a lot of people taking care of the patient and they range in the professional background. It's important for us to spend some time thinking and trying to improve teamwork because we spend a lot of time on these related activities. Time motion studies show that nurses and physicians spend about a quarter of their time on communication and coordination of care. Observational research shows that higher ratings of teamwork are associated with higher nurse retention, which is important because we've had a nursing shortage in the US, and that's only been worsened by the pandemic. Also, observational research shows that hospitals with higher ratings of teamwork have higher patient satisfaction. But probably the most important reason for us to dedicate some time and effort to teamwork is this tight association between communication, which of course is essential for teamwork, and patient safety. There's a body of literature supporting this. I'm going to just give you 3 examples. The first is a study by Kathleen Sutcliffe and colleagues at the University of Michigan, where they interviewed residents and asked them to describe medical mishaps in which they had recently been involved. They didn't know what themes would emerge, but the dominant theme by far was communication failure, involved in 91% of the mishaps described by the residents. The Joint Commission, as many of you know, tracks sentinel events. Those are adverse events that result in serious harm. Usually root cause analyses are done on these. These are reported to the Joint Commission. They track this information. And over many years, about 2/3 of sentinel events involve communication failure. And again, observational research has shown that hospitals with higher ratings of collaboration on the part of nurses have lower adjusted mortality. And this is something you're going to hear me kind of emphasize over and over again, is the importance of nurses' perceptions of collaboration. That'll become apparent to you why I emphasize that as we go through today. I want to talk about some key teamwork concepts. There's several different frameworks for teamwork. The one that I like best is this one developed by Eduardo Salas and his colleagues. He has studied teams for decades, starting in aviation and the military, more recently in healthcare, and says that there are 5 core components to teamwork. The first is team leadership. Team leaders effectively direct team member activities, help resolve conflict, try to achieve consensus. Mutual performance monitoring is the ability of one teammate to monitor another's performance, anticipate their needs, and if there's a need, to provide backup behavior to help them out. Adaptability is the team's ability to take in information about the performance and adjust strategies. And then the final component is team orientation, which is the notion that individuals on the team put the team's goals ahead of their own. When all of these components are working well, the team develops a shared mental model. A shared mental model is an organizing knowledge of the tasks of the team and how the team is going to interact to accomplish their goals. You can think of this as being on the same page or reading from the same script. And I like to illustrate this with a picture of individuals that are not on the same page. So if you look at this picture, you can see that there's 4 people in hazmat suits focusing their attention on something that apparently is very dangerous right here. This person literally won't touch it with a 10-foot pole. And this guy over here, he's not on the same page with the other 4, right? He thinks that this is a photo op. He's wondering what all the fuss is about. So that's an example of a lack of a shared mental model. Another thing that good teams develop is situational awareness. Situational awareness is the ability of a team to pick up on potential threats to the team's performance. And here's a great example of a team that lacks situational awareness. Teams accomplish this through closed loop communication. So here's an example of communication that could be occurring at most hospitals in the US right now. There's a physician in one part of the hospital returning a page from a nurse in another part of the hospital. Physician says, "You paged me?" And the nurse says, "Mr. Jones has more pain." Physician says, "Let's increase his hydromorphone to 4Q2. And the nurse says, "Okay." If we were together, I'd be looking at your faces and I'd probably see many of you kind of cringing, about all the issues with this dialogue. There's lots of issues. I picked Mr. Jones, but there are many times when we're caring for two patients with similar or the same name, there's an assumption that the physician knows why the patient has more pain. But we don't know whether this is a new pain, a different pain, a worsened pain. There's a lot of hydromorphone being given to this patient. We're not sure whether that's a change from something before. We don't know who's putting in that order. Is the nurse taking a verbal order? I'm not sure. We could go on and on. What if the conversation looked like this? Physician returning a page from a nurse. Physician says, "This is Dr. Steinberg. I was paged." And Dan would do this because he understands the importance of closed loop communication. The nurse says, "Mr. Jones has more pain." Physician realizes he needs to make sure they're talking about the same Mr. Jones. "Mr. William Jones in 1302 has more pain?" Nurse says, "Correct." Physician says, "Yes, I just saw him," implying I've already assessed him. I'm putting in an order for hydromorphone 4 Q2. So now we know who's putting in the order. The nurse now reads back what she understands is the order. "So you're increasing the hydromorphone from 2 milligrams IV Q2 hours PRN to 4 milligrams IV Q2 hours PRN?" The physician says, "Yes, that's right." I know what you're thinking. That's a lot of hydromorphone. All the more reason why we should get this right. It doesn't usually happen like that, though. If we're honest with ourselves, we don't usually communicate this effectively. And actually, there's some pretty good research to show that we often don't communicate at all. This is information from 2 studies, one by Brad Avanoff at Washington University Barnes Hospital in St. Louis, and one done by our research team when we first started working on this years ago at Northwestern Memorial Hospital. I've combined the data because we used very similar methods. Basically, we randomly chose patients, and then we interviewed their nurse and their physician in the late afternoon. So enough time for communication to occur if it were to occur. And we asked the nurse, "Do you know the name of the physician taking care of the patient? Have you communicated with the physician? If so, how?" Asked the physician the same questions. Nurses knew the name of the physician taking care of their patients 40 to 70% of the time, the difference being the 2 different studies. Physicians knew the name of the nurse less often, 20 to 40% of the time. They reported discussing the plan of care with one another about these specific patients only 50 to 60% of the time. 2/3 of the time that was face-to-face, but 1/3 of the time that was just a brief phone call or a text page. In our study, we took it a little bit further and we asked nurses about the specific patient. What was the diagnosis that landed this patient in the hospital? What are the planned tests for today? What are the planned procedures for today? What are the medication changes planned for the day? And we wrote down verbatim what they said. We asked the physician the same thing. And then we looked at these and rated whether they were in agreement or not. And we gave the benefit of the doubt. So if the nurse said the patient was here for chest pain and the physician said the patient was here for acute coronary syndrome, we said they're essentially saying the same thing and we'd give them full agreement for that. But even with that flexibility, there was no agreement between the nurses and the physicians 26% of the time for diagnosis, 26% of the time for planned tests, and you can see the results for planned procedures and medication changes. In other words, they were not on the same page. They did not have a shared mental model. Again, going back to the work that we did at Northwestern when we were first trying to characterize this, we did a simple survey. We used the Safety Attitudes Questionnaire Teamwork Climate. I'm not showing you those results, but I refer to it just because I think it's a great survey. We also, in that survey, asked respondents to rate the quality of collaboration that they had experienced with other professional categories. And what I'm showing you here in these tables and these figures is the percentage of respondents in one professional category rating collaboration with the other as high or very high quality collaboration. So to walk you through this on our teaching service, 72% of residents rated the quality of collaboration with nurses as high or very high quality, but only 35% of nurses rated the quality of collaboration with residents as high or very high quality. Same story on the hospital service, which really surprised us because for years we'd been telling ourselves that we understood the importance of communication, we were more mature, more stable, and yet the nurses were almost as dissatisfied with us on the hospital service as with residents on the resident service. Now, lest you think that this is old data, this is from 2010, maybe this is just an issue at Northwestern. This is data from a reset project that I'm going to tell you more about a little bit later. These are 4 hospitals in different parts of the US. And this is the baseline collaboration survey, very similar to what I just described, that was administered on their medical services. Very similar results, where we see that 63% of the hospitalists in these hospitals rated the quality of collaboration with nurses as high, but far fewer nurses rated the quality of collaboration with hospitalists or very high. So I'm really making the point that this dyad is really key, the nurse-physician dyad. When we look at others, I haven't showed this to you, but when we look at other dyads, for example, hospitalists or residents and social workers, they tend to rate collaboration with one another pretty highly. I'm going to try to look at the, gotcha, okay, that's, so I'm going to keep going here. I was just looking at the chat there for a second, but now, there we go. So this is the way we put this together. There's ineffective communication, which leads to an incomplete understanding of the plan of care, lack of a shared mental model. That then becomes the norm. People get used to not having a complete understanding of the plan of care. They're not even aware of the fact sometimes, which means that they don't seek out the additional information that they need. That all contributes to a system which has limited ability to catch or prevent errors before they reach the patient. So let's talk about barriers to collaboration and teamwork, because no one comes to work, no one wakes up in the morning saying, you know what, I'm not going to collaborate or communicate effectively today. It's just not my thing. That doesn't happen. It's really, the issue is that there are all these other things that get in the way. And so when we were looking at this, trying again to define this issue for ourselves at my hospital, we went back to the literature, went back to the work of Eduardo Salas, also looked at work from Lemieux Charles, and really 3 things come up over and over again when you look at teams in any setting. One is team size. Sometimes the team is too small, but more often the team is too large. Second, team membership instability. That means that team members are joining and departing from the team as the team is doing its work. And the last barrier is dispersion of team members in time and place. Now, these researchers were commenting on teams outside of healthcare, but those are exactly the system barriers that we have in hospital settings. Remember that I asked you to take that mental snapshot of that patient in the beginning, in the middle, with all those professionals around. It's a huge team that takes care of our patients in the hospital. And that was just a snapshot. We've got team membership instability because we provide care 24/7, 365 days a year. So physicians are leaving for the day, signing out to night float, going on and off rotations. Nurses, of course, and other professionals work in shifts. And then dispersion of team members. We've got that uniquely on medical services. So the best way I can illustrate this to you, I know it's familiar to you, but I'll show you this example of what life looked like for me before January of 2008 in my hospital. I might have a patient on the Feinberg Pavilion 13 West. I might have another patient on 13 West. I could have a patient on 13 East. And in fact, I could have patients back then on 9 different units on 5 different floors. And some of those floors were separated by other floors. It was really hard for me to collaborate with the nurses who are unit-based. In our hospital, our social workers, our pharmacists, our therapists are also unit-based. Really hard to collaborate with those other essential team members. A different hospitalist on at the same time would have an entirely different distribution of patients and the same challenges trying to collaborate with the unit-based team members. You can substitute, these are hospitalist examples, but you can substitute resident teams with the same concept. So let's talk about interventions. Again, just kind of retracing what we were doing at Northwestern in the past. We went back to the literature, tried to see what had been published with regard to interventions. Lots of work in teamwork training, especially in operating rooms and intensive care units. Interestingly, those are locations where team members traditionally have been at the same place at the same time. We thought that there were major systems issues that teamwork training would be difficult if team members were hardly ever in the same place at the same time. So we looked at geographic localization of physicians. I'm going to share with you some research on that. Unit-based co-leadership, I'll talk about that a little bit too. First site that really published some information about that was the University of Pennsylvania. Daily goals of care forms and checklists. I'm sure you're aware of lots of research and quality improvement using those structured communication tools, mainly in operating rooms and in ICUs. Again, it's interesting that in those areas, the team members have traditionally been in the same place at the same time, but don't necessarily get on the same page until they use a structured communication tool. And then interdisciplinary rounds, we'll talk about that quite a bit. So this is the first thing that we did in my hospital. Beginning in January 2008, we went from this model that I showed you earlier to this, where we basically assigned physicians to two units, and they had all of their patients on 2 units that were near each other. So not perfect, not 1 unit, but 2 units way better than 9 units. This essentially was changing our admission system so that patients were first assigned a room and then later assigned a physician and a service. There's a good number of, and a growing number of studies that have been published that have looked at the impact of localizing physicians to specific units. And here are the results. There's increased recognition of team members, so the team members know each other's names more often, which I think is important to facilitate communication and rapport. Increased frequency of face-to-face nurse-physician communication rather than pages and text pages. Reduction in the pages to physicians. I'm sure everyone in the audience would appreciate that. There's not a whole lot of information on other outcomes, but most importantly, this provides the foundation for other interventions to be built. There are keys to success, and this is gleaned mainly from experience and lots of conversations with people, and a little bit from the studies that I just mentioned as well. One of the keys is to partner with the stakeholders, and the stakeholders are many, but in most hospitals, they include bed assignment or a similar department in your hospital that goes by perhaps a different name, the emergency department, residency program. Don't shoot for perfection. So the hospitals that have been successful in this usually try to aim for a goal of 2, and 2 is way better than more than 5. They often leverage the handoff of the night admissions. Roughly half of admissions in most hospitals come to night float, and so all of those admissions theoretically can be handed off. They're going to be handed off anyway. They can be handed off to a localized team. Prioritizing localization over daily census equivalents. So the idea there is that physician workload is going to even out over time. So I think it's okay for one physician to have 14 patients while another has 12 on any given day, if over time that's going to even out. And I think having 14 patients on 2 units is much better than having 14 patients on 5 units or more. Most places find that it's important to designate a physician to admit at all times. I know that you guys have a drip admission system that's conducive to this sort of a model. And really important, most hospitals who do this have a contingency plan, something like a sweeper or an overflow hospitalist. In the model, there's one physician or team that's not localized that can be deployed to any unit that's getting a surge in admissions, and that allows the others to stay localized. So that's some data on localization. Here's some of the research on interprofessional rounds, and I'm sharing with you 3 systematic reviews. And the frustrating part here is that they have different findings, and I'll explain why in a minute. But the first is by Panic. This was published in JAMA Internal Medicine. He found that there's some evidence to support that interprofessional rounds improve patient safety, but no evidence to support a difference in length of stay. Bamadipati found different results. She found that there's evidence to support improved length of stay and staff satisfaction, but very little data one way or another to support an impact on patient safety or satisfaction. The final one is by John Rattel, and he specifically looked at bedside interprofessional rounds. The first 2 systematic reviews combined rounds that occurred at the bedside or in other locations. John looked at specifically bedside interprofessional rounds, wanted to look at patient-centered outcomes, and found a small improvement in patient experience, but pretty small, and no improvement in patient knowledge. One of the reasons why these results are different, I think, is because the interventions are typically implemented and evaluated in isolation, meaning that I mentioned the localization research and I mentioned the interprofessional round research. Often the studies only implement one, but not the other, when really implementing one only addresses a portion of the system's barriers, and really these should be considered complementary interventions. So I think it's much better for these interventions to be conceptualized as complementary, mutually reinforcing, and that they should be implemented and evaluated as such. I'm going to talk a little bit more about that as we go forward. First, I want to tell you about the Interact study. So this is a study that we did at Northwestern. So after we localized our physicians in 2008, we then put into place 2 additional interventions, unit co-leadership and structured interdisciplinary rounds. Unit co-leadership involved the creation of a new role for us, the unit medical director, and the nurse manager and the unit medical director were supposed to be jointly responsible for quality on their unit. We put them through co-leadership training. One of the most important things that we did in training was simulation training to help them facilitate structured interdisciplinary rounds. SIDR combines a structured communication tool with regular interdisciplinary meetings. The nurse manager and the medical director facilitate the conversations and rounds. And one of the stipulations then when we designed this was that all nurses, bedside nurses, physicians, pharmacists, social worker, and case management would attend. Key was that this was designed from the bottom up. So we gave some parameters around which and some goals with which the team, the working group could use, but we really wanted frontline professionals to decide the optimal format, timing, frequency, duration of SIDR, and the best use of the communication tool. We piloted this on 2 units, one teaching service unit, one hospitalist service unit. Both of them decided that they would do this in conference rooms in the late morning. A lot of discussion about doing it at the bedside, but the working group really felt that that wasn't feasible. And they came up with this structured communication tool that they decided would be used on new patients. The idea being that new patients have the most kind of uncertainty and the most need for team members to get on the same place, on the same page. But then they would also discuss older patients, not the newly admitted ones, but really just with a brief update. This is not completed. This is really just to organize the conversation during SIDR. We collected a lot of fidelity data to make sure that this was actually happening as planned, and it was. And here's the outcome data. We didn't show an impact on length of stay or cost. We were disappointed with that, but we didn't have much room for improvement on length of stay and cost. When we compare ourselves to benchmarks in the Vizient database, we actually have traditionally done pretty well in length of stay and cost. Professionals rated these interventions favorably. They actually thought that unit co-leadership and SIDR improved the efficiency of their workday, and they wanted it to continue, which was key. We found significant improvements in teamwork climate, and then also the ratings of collaboration, which I'm showing you here at the bottom of this slide. You can see here on 2 control units that physicians continued to rate collaboration with nurses very highly, and nurses continued to rate collaboration with physicians relatively poorly. On the intervention units, you can see that the nurses were much more satisfied with collaboration with physicians. And this difference, I didn't put it up here, but it's statistically significant. More importantly, we found an improvement in patient safety. So we did a chart review using the IHI trigger tool, and we found on a control unit that there was an adverse event rate of 7.2 per 100 patient days. On our intervention teaching service unit, an adverse event rate of 3.9 per 100 patient days. That's a 46% reduction in the rate of adverse events. This was a concurrent control, but we also looked pre-post on that intervention unit and found a very similar 46% reduction in adverse events, which we were really pleased to see. There are other models out there, and I want to share this with you. Jason Stein has developed this accountable care unit model. Ariba Kara at Indiana University has developed a similar model called accountable care team model. These components both have unit-based teams. That means that the physician localization, which we've been talking about, unit level nurse and physician co-leadership, structured interdisciplinary bedside rounds, or CIBER, as Jason likes to call it, He really thinks that these interprofessional rounds should occur at the bedside and unit level performance reporting. These have been studied. I will tell you that the rigor of the research is kind of medium. The implementation of the model has been associated with improved length of stay and cost, but not patient satisfaction. Importantly, patient safety was not assessed. And as I've been trying to emphasize, I think that of all the outcomes that can be improved potentially with improved teamwork, patient safety, I think, is the most plausible one. All of these models are basically taking a systems approach, and what they're doing is focusing and trying to redesign clinical microsystems. So clinical microsystem is defined as the small group of people who work together in a defined setting on a regular basis to provide care. You may or may not have heard of this term before, but I'm sure you're familiar with the concept because you all work in microsystems. A hospital unit is a microsystem. Microsystems coexist with other microsystems, emergency departments, ICUs, procedural suites, diagnostic and testing areas. All of these are clinical microsystems which exist within a larger mesosystem of the hospital and a larger macro system of a health system or network. We also know that that high-value organizations, both inside and outside of healthcare, the organizations that operate, that perform exceptionally well, even under stress, that they tend to deliberately design microsystems to optimize their performance. That's one of the secrets to their success. And there's great literature by Julie Johnson, one of my colleagues here, and Nelson and others, that effective clinical microsystems have certain components: local leadership, focus on the needs of staff, emphasis on needs of patients, attention to performance, and rich information environment. More or less, these things map to the interventions that we've been talking about. So I want to tell you about this study that we're currently doing called the Redesigning Systems to Improve Teamwork and Quality for Hospitalized Patients, or RESET. This is a partnership with the Society of Hospital Medicine and the American Nurses Association. After we did our work here at Northwestern, we wanted to see if some of the same issues and the same benefits could be achieved in other hospitals. And so that's the premise behind RESET. The specific aims are as follows. The first is to conduct a multi-site mentored implementation study in which each site implements complementary interventions to improve care for medical patients. So the key there is that we provide mentorship to the sites in the study. The second aim is to evaluate the effect of the intervention set on teamwork climate and patient outcomes related to safety, patient experience, and the efficiency of care for medical patients. So we want to see if these interventions, if implemented successfully, if they improved outcomes. And then the third, and I think actually the most important aim, is to identify factors associated with successful implementation of interventions. These are really, it's really hard to redesign systems. And we wanted to understand why a hospital might be successful or might not be. So after we got funding in late 2017, we had an open call in collaboration with SHM and the American Nurses Association, and got 14 applications from around the country and selected 4 sites. The sites have asked me to protect their identity, so they're anonymized here. And I will tell you that all of these sites are mid-sized hospitals. 2 of them are teaching hospitals. 2 of them are community hospitals with no teaching, no residencies, but none of them are major affiliates of a medical school. We're asking them to, we're using the advanced and integrated microsystems interventions. So very similar to the interventions I've described for the last 15 minutes or so. This should all sound familiar to you at this point. Unit-based physician teams, that's localization of physicians to specific units, unit nurse physician co-leadership, enhanced interprofessional rounds, so really emphasizing that these should be designed with input from frontline professionals. We've encouraged sites to do this at the bedside, but it's not a requirement. Unit level performance reports, so data available at the unit level on how performance is going, and patient engagement activities, which include, again, encouragement to do interprofessional rounds at the bedside, but also doing nurse bedside report at the bed, doing nurse change of shift report at the bedside as well. In addition to the mentorship that we provide them through a nurse and physician mentor, we developed an implementation guide, pretty detailed, and this is freely available to you as well. It's available on the SHM website. Lots of tools in here. Probably the most important thing is that there are strategies to navigate the challenges that frequently come up as sites embark upon implementing similar interventions. The measures that we're looking at include our primary outcomes are collaboration and teamwork climate. And I'm going to share some of those results with you. The other primary outcome is adverse events. I don't have that data yet for you. The data collection is ongoing and we haven't analyzed that yet. Secondary outcomes also forthcoming include patient experience, length of stay, and 30-day readmissions. We asked the sites to collect Fidelity, and I'm trying to emphasize this because many times I talk to people and they say they're implementing these sorts of interventions, but they don't really know objectively how well it's going. So at these sites, they all have a research nurse who has a portion of her or his time funded to collect this Fidelity information. I'm going to share you an example with you in a second. And then we're collecting qualitative data again to try to understand what are the factors associated with successful implementation. This is a busy slide, but not meant for you to look at individual cells. Just want to give you an example of what the Fidelity data looks like. So at the top, these are two measures of the effectiveness of localization. So you can see in this row the average number of units that the physician has patients on. This is the physician who's designated for this implementation unit. And you can see it started that the physician had their patients on an average of 3 units, and then it improved to like 1 or 2 at the end of this time period. The percent of that physician's patients localized to that unit is another thing we look at. And that was pretty high, throughout this time period, 84%. This is an example from just one site, a site that actually is doing pretty well. At the bottom are these Fidelity measures related to interprofessional rounds. And you can see that interprofessional rounds were generally occurring on time, that the percentage of unit patients discussed in interprofessional rounds improved over time, meaning we'd like all of the patients to be discussed during interprofessional rounds. The duration of rounds, the attendance of rounds, and down at the bottom, you can see that the location in this hospital was at the bedside, and it kind of improved a little bit over time. So that's really just sharing that with you to emphasize that any hospital that's considering implementing something similar should really collect some objective data to make sure it's going well. We collected, we administered surveys at baseline in Reset, and then at the end of the first phase of implementation about a year later. And you can see in blue the baseline rate of hospitalist collaboration with nurses. It went up at the end of phase 1. This wasn't a statistically significant improvement, but numerically it improved. The nurses' ratings of hospitalists went up at the end of that first phase of implementation, and that was statistically significant. So we're pleased to see this. This is data that hasn't been published yet, but I wanted to share some results from this project with you. The factors that have been associated with successful implementation, we're still not done with this qualitative analysis, but these are our findings so far. And I hope that this is helpful for you. This is really probably the best contribution that we can make to other hospitals that are considering something similar. In general, the hospitals in our Reset study that have done well have had committed and stable leadership at all levels, meaning some hospitals have had some turnover in leadership, or the leadership hasn't been fully committed, and that's been a challenge. The other general factor associated with success is assistance from the Quality Improvement Department. 2 of our hospitals engaged their Quality Improvement Departments to partner with the nurse and physician leading the Reset implementation, and that really helped them quite a bit. For specifically the components of unit-based physician teams, early partnership with bed assignment, nursing, the residency program has been associated with success in our study. And then the willingness to modify processes to assign patients to physicians. There's lots of different ways to do this. There's always a trade-off between continuity and some other factors. and assignment of patients. And the sites that have done the best are the ones that are at least willing to revisit that process. Unit nurse physician co-leadership, 2 of our sites have been able to obtain funding to protect a portion of time for the unit physician leader, and that's been really helpful in allowing that physician to serve in that role. And then for interprofessional rounds, goes without saying, but localization is really key. It helps facilitate effective interprofessional rounds because physicians, if they're asked to attend 1 or 2 rounds for their patients, they can do that. If they're asked to attend 5 different rounds on 5 different units, really hard to do that. 2 of our sites have also developed training videos for kind of examples of the optimal communication that should occur during rounds, and have done extensive coaching. They've joined rounds and helped people understand the types of conversations and making sure that there's closed loop communication in interprofessional rounds, and that helps optimize the discussions and make sure that people are on the same page. Of course, no presentation, I think, today can be complete without discussing the impact of COVID. And as you can imagine, we were entering year 3 as COVID started, and it had a huge impact on our study. Interestingly, the sites have been affected in different ways. One of the things that we've seen is that the COVID volumes have varied by site and time. As you have probably seen, as you've been tracking trends throughout the country, other countries have been, other regions of the US have been affected by surges at different times. There's basically been 3 waves, but for example, here in Chicago, that kind of late summer wave, we weren't affected by that at all. And similar, the sites had kind of different patterns of being affected by the COVID volumes. All of them had a huge decrease in their non-COVID volumes, which caused big financial pressures for all of the hospitals in our study. Now those non-COVID volumes have come up and they're struggling with staffing. There's been variable ability for the sites to maintain physician localization. The sites that haven't been, it's because it just isn't the priority right now. But 2 of the sites have been able to maintain localization pretty well. The co-leadership model has been universally helpful for the sites as they've dealt with these rapid changes in the unit patient mix as units kind of change to COVID or not, or a portion of them do, and as staff is redeployed from other areas of the hospital to help out on their units. Physical distancing and the minimization of larger groups has resulted in interprofessional rounds moving from the bedside, which was the case in 3 of the hospitals were doing bedside interprofessional rounds. Now none of them are. They're all doing interprofessional rounds in conference rooms. And perhaps most importantly, leaders in the teams are exhausted. You might be able to relate to that. Morale is low. So as we've been continuing to meet with the sites every month, we have not been pressuring them to renew their efforts. Really only 1 site is beginning to renew their efforts, but the others were really just kind of waiting for a window of opportunity. So hopefully I've given you some clarity on these concepts and terms that seem very confusing and overlapping and conflated. My recommendations, if your hospital is considering revisiting these sorts of interventions in the future, is to first assess teamwork and collaboration. I'd be happy to share with you the surveys that we use. They're freely available. I think that that's really key because that helps determine baseline and whether there's a need for change. In some hospitals, there may not be a need for change. If there is, it also helps you make the case for change. If a hospital is going to embark upon these sorts of interventions, it's important to make sure there's strong, engaged leadership at every level, at the level of leading the project to the people who are the executive sponsors above them, and at the unit level as well, and within the groups and the residency program. It's important to assemble a project team with representatives from all the key stakeholder groups: bed assignment, nursing, hospital medicine, residency. As I mentioned, partnering with quality improvement and performance improvement, if you've got a department like that in your hospital, is really helpful. Collecting fidelity measures really helps make sure that the interventions are being implemented as planned, and providing training and coaching for interprofessional rounds makes sure that the conversations are really high quality and that closed loop communication is occurring. So in conclusion, teamwork is essential for safe and effective care. We, especially physicians, may not be aware of the deficiencies systems barriers abound. It's almost as if our systems have been designed to get in the way of teamwork. The interventions individually appear to be successful, but more importantly, they complement one another. We need to test and evaluate the use of complementary, mutually reinforcing interventions that redesign systems. And importantly, implementation requires adaptation for local factors. There's not one model that fits each hospital, and hopefully you've heard me say that we've got different models that I presented to you, the AIMS, the ACU, the Interact model, lots of similarities, but they all need to be adapted for the priorities and for the constraints in any particular hospital. I've worked with lots of people over the years on this topic, and these are the RESET co-investigators. I want to thank them and many other people that I've had the pleasure to work with over time. I want to thank you again for the opportunity to present to you, and I would love to continue our conversation. Would love your questions, your comments. Would love to learn from you too.
Excellent. Thank you so much, Dr. O'Leary. I'm sure there's a flurry of questions. I'll let people either enter them into the chat or unmute themselves and ask away.
I'm looking in the, just checking the chat first, and I see from Alfred. Hello, Alfred.
Hi, Kevin. Yeah, to clarify, I was sort of referring to the, so while I think there are many among us who believe very strongly in geography, and as you pointed out, strict geography doesn't mean one doctor, one floor. It can mean a myriad of kind of what often might be referred to as more regionography or limiting distance travel. And I'm not going to try and debate the positive aspects which are there, which is people feel great. You presented some great data there about safety outcomes that we can prevent these large things. But out of MGH, they did it. They talked about their experience of moving to regionography. And I can't remember the exact reference. Dan Hunt was sort of the lead, or he wasn't the lead, he was senior on that. And what they did show is while everyone said teamwork goes way up and that, yeah, I know who the doctor is, and we talked about the plan and we agree on it. If you get to the nitty gritty of like asking, so is this patient getting a CAT scan? There was no real change in actual awareness of major planned events for the next 12 to 24 hours. I don't know how that fits into the schema that you're talking about, just because I'm interested, like, I think that teamwork is the first step, but then how do we cross that? Like, people think they talk to each other, but some of these interventions are very much geared towards a specific stakeholder and everyone's just along for the ride. And you look for the metrics that look good.
Yeah, thank you, Alfred. That study, I'm vaguely familiar with it. I don't remember all the details, but my recollection, I mean, you're right. These are, one, as I mentioned, the interventions are really, really hard to implement. But two, I think that study focused on the localization, and I'm not quite sure whether they had some of these other components. And that's kind of, one of the themes that I'm trying to emphasize here is that the localization in and of itself, and we found that too in our study many years ago when we did this, that actually people were not on the same page more often just with localization. So I think that that's the foundation, but then you need to build these other components onto it. So interprofessional rounds, unit co-leadership. That said, I will tell you that just having interprofessional rounds doesn't necessarily mean that people are going to be on the same page. The quality of interprofessional rounds really makes a huge difference. I can see that in my own hospital where I will visit the rounds on different units, and some of them are, rock stars, and others, it's like, they're talking, but no one's really connecting. We've seen that on our site visits too, and I could tell you some stories, but I'll spare them. But where the nurse and the physician are talking, and we're thrilled that they're in the same place at the same time, but they're not making the connection. So yeah, I think that that's for future work, and it's all of these things I think build upon one another. So the localization helps facilitate the interprofessional rounds. having local leadership helps make sure that those rounds are occurring, helps coach during those rounds. But those rounds need to be monitored and optimized to make sure that people really are sharing the information and listening carefully to make sure that they're getting on the same page.
Great. I think that answers it completely, that it comes down to setting up the leadership of this rather than just believing proximity will improve everything.
Oh, yeah, definitely.
Hi, Dr. O'Leary. I'm Beth Kronitsky. I'm one of our hospitalist attendings here and also our Deputy Chief Medical Officer. And I apologize, I joined a couple of minutes late, so I don't know if, I missed your introduction, and I'm not sure if anybody told you that we actually did sort of the reverse. We went against the current trend a couple of years ago. You probably know that. And we've been looking at putting our story together. And one of our key deficiencies, I think, since switching to non-geography is the lack of inclusion of our nursing colleagues. We were lucky enough to go non-geographic with our social work and case management colleagues. And so we were able to preserve, you know, a somewhat functional interdisciplinary team round process, but we have vastly cut out our nursing colleagues. And so that's, you know, that's, once we get out of wave 2, that's something that I will personally be revisiting along with a lot of people on this phone call who work to make that happen. So I just wanted to thank you for your presentation today. I was fascinated. I was texting offline about so many ideas that I have. So thank you for all of your thoughts.
Thank you, Beth. I appreciate that. Is my goal. If I can trigger a couple ideas, that is awesome. So you made my day telling me that. I think, you know, as long as a hospital is thinking about and trying to deliberately design their systems, that makes me happy. Ryan did tell me, I had a call with Ryan last week, and he did tell me that you guys have basically assigned some of the other professions to the team. So a case manager, social worker to the team. That makes a whole lot of sense to me. I know of other places that have done that too. And you're right, the only real deficiency there is the bedside nurse. Hopefully in my presentation, I've emphasized the importance of the bedside nurse. You might want to start just by doing some sort of assessment of nurses' perceptions. You know, maybe nurses are happy with things, and then there would be no need to redesign anything. If they're not, then that gives you some motivation to revisit your model.
Thank you. We know they're not thrilled, so we're working on it.
Yeah.
I was just going to say there was another comment in the chat about how we've been using Epic Chat. The question is, what I feel we've lost both on Epic Chat and in person is presenting ourselves and our role in the team. And so taking just a few seconds to state this makes communication smoother, provides better understanding of everybody's role in patient care.
Yeah. What I feel we've lost. Yeah, I didn't talk about the role of communication technology, but that's another interest of mine. And it's fascinating. We have Epic as well. We don't use Epic Chat. We were using Spoke, and then more recently we did a soft rollout of Vocera, which didn't go very well, predictably, because the physicians were on Vocera on their personal smartphones, but the nurses, the social workers, everyone else in most of the hospitals in our system were not given a device to use Vocera. And so, you know, half of my pages come from nurses and social workers. The other half come from physicians. But if not everyone on the team is on the same communication technology, then it's not really going to be all that helpful. So yeah, I think there's a lot of work to do to figure out what the optimal form of communication technology is. Trying to get at and thank you, Raina, for this comment. Yeah, so on Epic Chat, it doesn't designate the role of the individual. Is that It's just kind of an anonymous message from someone, but you don't know what role that person is?
You might not know if they're the intern or the resident or the attending.
Gotcha. And is there any way to provide some sort of template? You know, in our text paging system, we can configure it so that there's forced fields to fill out, role, callback number, that sort of thing. Is there any way to configure the Epic chat to say, that this is the intern and whether I want to call back or not, or the urgency of the message?
We have to take that up with informatics, I think, but it's an interesting point.
Yeah. There's lots and lots of, when I talk to people about these secure mobile messaging applications, lots and lots of stories of failed implementation. And it's really striking when you compare and contrast the amount of planning and effort that goes into implementing an electronic health record versus these secure mobile messaging applications. Often these are kind of assumed to be easy to implement, but I think they're actually very complicated. There's a study from Margaret that says, of the 4 hospitals that you were working with, do any involve patient partners in creating the bedside rounding communication tool? Margaret, thank you for that question. That's a great question. We strongly encouraged the hospitals to do this. Interestingly, only one of the hospitals had a really highly functioning patient and family advisory council. They did kind of late in their design have some patient representatives from the council help them, and actually they helped them create the video that they made for training. That was a huge help. But interestingly, the other 3, when they had their application, said that they had patient family advisory councils, but then when we started working with them, unfortunately, they weren't really effectively functioning. I think that partnering with patients is absolutely a great idea in these in building these interventions.
Evan, it's Dan. I just wanted to say thank you very much for really a world-class talk. I mean, the more that I have learned about this over the years, and there are many of us on the call who think about this a lot, and so to hear you speak with such expertise is really just, we're all just like texting in the background, trading ideas. And I've just learned that what can appear to be very, very simplistic, very binary geography or non-geography is actually much more layered and much more complex when you get into it. And really it comes down to understanding what each system offers and does not offer, and then pairing that against what your local environment needs, wants, can handle, which you said, but I mean, that's been the lesson for me. And I do think, for example, there are so many nuances in the literature. For example, you pointed to the study that said that there are less pages sent to physicians in a geographic localization model. But if you think about the number of interruptions, many would say that it's higher, because in a non-geographic model where the nurses have to page the physician, it does force a little bit of curating of the information and deciding and bunching it and such. We've all been in the back rooms where someone comes in and says, do you have 7A or do you have 5A? And when the team is geographically localized, the communication is easier, but that can also lead to more interruptions. And that's just one example of how many nuances there are in the literature. But thank you for a terrific talk.
Yeah, my pleasure. I'm glad that you found it helpful, and I'm happy to chat with you at any point. If I can be of help, just let me know.
Sounds like a great way to end this. Dr. O'Leary, thank you so much for joining us. Everybody else, and have a wonderful afternoon.